Let's start with cardiology part 2, past medicine question. An 82-year-old man presents with loss of consciousness, and his wife states that he complained of feeling dizzy before going pale in color and falling to the ground. Now, he was unconscious, for example, for approximately 1 minute, and on regaining consciousness, he was not confused and recovered within minutes. He denied any chest pain, shortness of breath, or palpitations, and he states that over the past few months he had had several episodes of lightheadedness. However, he has never lost consciousness before. So, this is the first instance of a similar history, but he's having added loss of consciousness. 7-day Holter was performed, and you notice that there are 3 episodes of bradycardia of 20 to 30 beats per minute, which correlated with episodes of pre-syncope. So he is basically having something called as pre-syncopal attacks. And finally, he had a syncope. Then other events, absence of P waves for 3.5 seconds. So what will you manage? How will you manage this patient? So the options are VVI pacemaker, biventricular pacemaker, AIR pacemaker, reassurance or this you can pause the video now and then think of an option, and then we'll come to the correct option. So this patient, we do an AIR pacemaker. Let's see how do we come to this conclusion. This is a pure sinus node dysfunction without atrial fibrillation or an evidence of AV block. So there is no evidence of AV block. An AIR or DDR pacemaker can be used, and most cardiologists choose DDR pacemaker since many of these patients go on eventually to develop AV block. Let's just confirm what are the permanent pacemakers, what are the indications of permanent. So first of all is sick sinus syndrome. This can be due to brady or tachy. Symptomatic brady, no, even tachy can cause sick sinus. And there can be tachycardia. Complete heart block and persistent AV block after an MI, along with Bowman's type 2 AV block. But this should not be the option here. Sick sinus syndrome can be difficult to manage as it can present with bradyarrhythmias or tachyarrhythmias, a mixture of both. Okay? Bradyarrhythmias can be well controlled with pacemakers, while tachyarrhythmias respond well to rate limiting drugs like calcium channel blockers or digoxin or beta blockers. However, drugs to control tachyarrhythmias may exacerbate bradyarrhythmias. Therefore, a pacemaker is often implanted before drug therapy is begun for tachyarrhythmia. So, in both cases, you will require pacemaker. But in tachyarrhythmias, you will additionally give rate-limiting drugs. Now, with the patient, we had performed 7-day Holter, and in that, it confirmed that the patient had bradycardia. So, an episode of sinus arrest was there. What do you mean by sinus arrest? Absence of P waves more than 3 seconds. This was 3.5 seconds, right? So 3 seconds. This confirms that there is a diagnosis that there is some problem with the SA node, that is sick sinus syndrome. Now, this patient have been having symptomatic bradycardia and episodes of secondary SA node disease. Therefore, they are putting an AAIR pacemaker. AAI pacemaker both sense and pace the atrium. So, how do we define the pacemaker? Sensing. Second letter is pacing. Then third letter, whether it is inhibiting or uh, reducing or something. Then there are useful for isolated SA node disease. If you just want to focus on the SA node, in this case you will put an AA node. But they are not suitable in patients with atrial fibrillation, obviously, because the atria is not working well. Then VVI pacemaker will be ventricle inhibitory. Will sense and pace both ventricles, and either they will use of pure sustained slow atrial fibrillation. So in this case, what we do is that we directly go and stimulate the ventricle. We bypass the atrium. Then biventricular pacemakers we use in heart failure with left bundle branch block. If bisoprolol rate limiting would worsen the bradycardia in the patient. Let's just elaborate a bit more on the pacemakers. So what are the modes of pacemakers which we have? Pacemakers, we have a pulse generator, and then we have the pacemaker leads. Yeah, so this pacemaker generator, pulse generator, is on the left anterior chest wall or in the axilla. And then you have the leads which are inserted in the atria or ventricle. So what are the usual contraindications we have to pacemakers? We can't do MRIs or any diathermy cannot be performed. Nowadays, you have an MRI compatible pacemakers, which are usually leadless, and other you modify the settings before doing an MRI. So indication are of permanent pacemakers we have already seen. Uh, what are the configuration of pacemakers? So as we said before that there are different modes of pacemaker. We have the VVI or VVR or AAI, and we have the AO. What is the first letter which is telling you? It is telling you the chamber that is paced. Second letter is telling you the chamber that is sensed. And the third letter is telling you the response to the sensed event. What are you going to do after sensing? Either you're going to trigger or you're going to inhibit or you are going to do both. That is dual, depending on what you want to do. Or you can reverse. So, and the fourth character fourth letter will tell you the rate responsive. Then it can be triggered in between reverse or dual. So this is how these will be the modes of various pacemakers. We'll see one by one what do these ventricle sense, ventricle paced, either it is inhibit or it is reverse. So this is usually used in pure sustained atrial fibrillation. Why an atrial fibrillation? Because the atria is not functioning. It is not functioning at all. And it cannot be paced if it's not functioning. As they are insensitive, hence they need to be overrided. And ventricles are paced directly. The ventricle is sensed, ventricle is paced. If the QRS is detected, it does not fire. But if the QRS is not detected, it will fire. So where it will be used in pure sustained atrial fibrillation, or we can use it in AV blocks. Then you have AAI. So atria are sensed, atria are paced, and atria can be inhibited if required. So where is this placed? This is placed in the right atrium. So what it does is it will inhibit, as it says, it will inhibit the pacing output. It will inhibit the pacing output in response to an atrial sensed event. So this will give you a better hemodynamic clinical feature than dual chamber. And this is actually best for sick sinus syndrome if the patient does not have, without any AV block, or any conduction disorder, pure sick sinus syndrome. And this essentially relies on the AV node to fire. So the AV node needs to be in good health and guarantees a certain atrial rate. This is the function of AAI. Then you have AOO. What do you mean by OO? No sensing, no pacing, no response, and the pacemaker is off. Okay? So this is just going to sense the atria. And this is asynchronizing pacing or continuous pacing of the atria, irrespective of presence or absence of the intrinsic rhythm. Where is this indicated? Pacemaker dependent are subjected to artifacts, some pose electrocautery during surgery, or systole due to oversensing and pacing. That time you will put this basically you're going to change the mode of the pacemaker. Then we have what are the permanent pacemakers? Where do we put insert permanent pacemaker? If the patient has got persistent symptomatic bradycardia, example SSS, or if the patient is having complete heart block, or if the patient is having Mobitz type 2 AV block, or the patient is having persistent AV block after an MI. Now, in case of bundle branch block, unexplained syncope, but if the patient has got a left ventricular ejection fraction of more than 35%, you proceed with further testing. You do carotid sinus massage, you do electrophysiological studies prior to the initiation of management. Okay? The other thing you have to do before inserting a pacemaker is to exclude any other probable cause of syncope or collapse before installing any device. What are the non-post MI causes for pacemaker? Indication for pacemaker will be symptomatic secondary or third degree heart block, hemodynamic compromise if the patient has got ventricular tachycardia, which is secondary to bradycardia. Then early signs. Okay, so this is all about pacemakers. If there is anything else, we will be checking those out as and when we go ahead in this. So this should be clear. What are the indication of permanent pacemaker, and what exactly do you mean by VVI or AAIR? I hope this is clear. Then we come to 49-year-old Afro-Caribbean is diagnosed with hypertension. And he has no significant past medical history, remains asymptomatic, 24-hour blood pressure test, which of the following drugs should be used initially to lower the blood pressure. So you don't have to forget that this patient is an Afro-Caribbean. You usually see two things in it. One is the race, then if the patient is diabetic or non-diabetic, and whether he is beyond 54 or less than 50. So three things you will do before giving any antihypertensive. So we have this category, and you have to select which one will you, which option will be the most appropriate for this. So usually we start with the B's, calcium channel blockers in Afro-Caribbean people. The patient has stage 2 hypertension, and because he's Afro-Caribbean, we start with, I think hypertension was pretty clear cut in everybody's mind. Does not require much intervention at this point. You need to check what are the targets for blood pressure. Less than 180 is 149, more than 80, 150. 54-year-old female with heart palpitations. There's no past medical history and takes no regular medication. And her cardiorespiratory examination is normal. And ECG is performed, and the rate and rhythm is 145 beats per minute, regular rhythm. QRS is 145, and the patient has got this RBB pattern. QTC is more than 420, and axis, the patient has got right axis deviation. What is the most likely option explanation of these ECG results? Ventricular tachycardia, supraventricular tachycardia with bundle branch block, torsades de pointes, atrial fibrillation with BBB, and supraventricular tachycardia. Just check out 54-year-old female palpitation. So the answer will be supraventricular tachycardia with bundle branch block. Let's see why is this option the answer. Now, here basically we have to distinguish between ventricular tachycardia and supraventricular with MBV. The presence of right bundle branch block and right axis deviation favors a diagnosis of SVT with bundle branch block. ECG results confirmed a broad complex tachycardia. So you just check whether it's broad complex, narrow complex. SVT can be both. Okay. Now the differential diagnosis between SVT and bundle branch block and VT, you have to distinguish between VT and SVT. What are the features of ventricular tachycardia? There will be no association between atria and ventricular. AV dissociation, you will see fusion or capture beats. You will see positive QRS concordance in chest leads. And what are the chest leads? V1 to V6. Marked left axis deviation and ischemic heart disease history. QRS more than 160 centimeter. Lack of response to adenosine or carotid size. So these are the things which go in favor of ventricular tachycardia, right? These are the things which go in favor of ventricular tachycardia. If you check out the ECG, if you check out the question again, let's go to the question. Here you have a female with palpitation, no regular ECG. Now the rate is okay. QRS, it's less than 160. Has got an RBB pattern and it has got RAD. We require LAD for axis deviation for ventricular tachycardia. And what else do we require? Good response to carotid sinus. Lack of response to carotid sinus. And fusion or capture beats. just let us resolve this clinical conundrum of ventricular tachycardia versus supraventricular tachycardia. So here you can see, I hope you can see, the regular broad complex tachycardia can be either ventricular or supraventricular in origin. And the differentiation between the two will significantly influence the management of your patient. So unfortunately, ECG differentiation is not always possible. So you need to have some pointers to help you diagnose these conditions. One, ventricular tachycardia, SVT with aberrant conduction due to bundle branch block. Then you have all both of these differential diagnosis. ECG, which increase the likelihood of ventricular tachycardia, are if you find an absence of typical RBB or LBB morphology, if you have extreme axis deviation, northwest axis, that is QRS is positive in AVR and negative in 1 and AVS. AVR is positive for QRS. Very broad complex, more than 160, this we saw, plus AV dissociation, that is P and QRS complex at different rates. And P waves are often superimposed on QRS and may be difficult to dissolve. Then capture beats. We see what are capture and fusion beats. So capture beats occur when the SA node transiently captures the ventricles in amidst of AVDC dissociation, producing a QRS complex of normal duration. So QRS is normal in capture beats. Fusion beats occurs when a sinus and ventricular beats coincide to produce a hybrid complex, and this is called as Dressler beat. So when you see this diagram here, you are getting something which is hybrid. It's a fusion beat. So you can see something between the P and a QRSY complex. You have the normal rhythm going on, and then you have this. In this, the QRS is wide and appears as something between the ventricular beats and the normal beats. And this is a fusion. So in this, the QRS is normal. Then the capture beats, these beats are presumably supraventricular beats. And that managed to get through and depolarize the ventricles. So these are called capture beats. Note that these beats display large Q waves, which indicate prior myocardial infarction. Don't focus on that. Focus on this. Okay? This is fusion and this is capture. Yes, I said chest leads. Sorry, chest leads you will have AVR. AVR is positive and negative 1 and 8. So, through the precordial leads, you will have a positive concordance. You need to know the baseline here. Suppose this is the baseline and it is towards the upper side. So, it is positive. You want to see, you can see it's negative also. You can see one and show entirely positive R complex. No RS complex C. You can make out these are positive R from the V5, V3. All these are positive R. Negative concordance is this. Because this is a baseline. You can see that the R wave is towards the downside. S wave notched and slurred is S. And this is the Brugada sign, this is the Jobson sign, the RS. This is not required at this point. Again, let's just check out what are the clinical factors which are associated with VT. You will have age more than 35 with structural heart disease. The patient might have ischemic heart disease, previous history of myocardial infarction. The patient might have family history of certain cardiac disease. So anything which you're thinking of HOCM, long QT syndrome, brugada, arrhythmogenic right ventricular dysplasia. Then likelihood of SVT with aberrancy with previous ECG showing a bundle branch block. Remember, if you're seeing a bundle branch block, it's probably SVT. If it's not saying it's VT, then show evidence of WPW. Okay. Then you have an Lugada algorithm based on all of these. You can check this out on NIT as well. Anyways, I just hope you got the idea of what exactly uh, are we looking for when we want to differentiate between ventricular tachycardias and supraventricular. Let's just check out this question. A 38-year-old man is referred to the pharmacological clinic for review, and he's currently managed on hypertension with three antihypertensive agents like ramipril, amlodipine, indapamide, and his GP is concerned as he has still not achieved blood pressure targets. Now, on examination, his blood pressure is 155/95 and pulse is 78 beats per minute and regular. And there are no heart murmurs or bruise. So, abdomen is soft and non-tender with no masses, and his body mass index is 24 kilo. Investigation: sodium, potassium is 3.1, bicarb is 30, urea is 7, creatinine is 9. Now, which of the following is the most likely diagnosis? Potassium is less, bicarb is this. Which of the following is the most likely diagnosis here? They're asking for Barter's, Pons, Cushing's, Licorice, or what? Now, if you want to all these are causes with either hypo or hypertension and hypokalemia. Think like that. Okay, which of the following will cause hypokalemia with hypertension? So, out of all this option, Conn syndrome is the one which will cause hypertension along with hypokalemia. Don't forget this because this is a very important question. You can forget all of them, but remember this. Hypertension with loss of potassium is Conn syndrome, also known as what is Conn syndrome also known as? Primary hyperaldosteronism. Hyperaldosteronism. So this patient has resistant hypertension with hypokalemia and high bicarbonate despite initiation of three different antihypertensives. So you will think of resistant hypertensive causes when the patient is not able to control his blood pressure despite all the regular treatment. Now, out of both all these options, these two options cause hypertension with hypokalemia. But more common is this. So out of both of them, if you have to choose one, you will obviously choose consonant. Let's just check out what are the secondary causes of hypertension. Now, most of the patients will have primary hyperaldosteronism, 10%. The maximum of these only cons one, and is the single most common cause of hypertension. Now, renal disorders account for a large percentage of other cases of secondary hypertension conditions, which may increase the blood pressure. So, glomerulonephritis, pyelonephritis, ADPKD, RAS, renal artery stenosis. Endocrine में कितने हैं? 3 हैं. Theochromo, Cushing's, and Liddell's. Then you have congenital adrenal hyperplasia, can be 11, 21, and acromegaly. So all these conditions will come with hypertension. What are the drugs which cause steroids, monoamine oxidase inhibitors, MAO inhibitors like seligerine, dasagerine, combined oral contraceptive pills, NSAIDs, leflunomide, and even antacids can cause hypertension. Other causes include pregnancy and coarctation of hair. 45-year-old gentleman is advised by the GP to attend hospital following a routine blood test demonstrating an increase in creatinine 2 weeks following a increase in his ramifil. Now his ramifil was increased from 5 milligram daily to 5 milligram twice daily. He has letter which demonstrates investigations, results shown below, and he reports no new symptoms. Reports that home monitoring of blood pressure has shown his control to be better. So he showed his ramifil and we managed and monitored. So whenever we are giving ACE inhibitors or ARBs, we are very vigilant of renal function test because we expect a 25% rise in the RF days. Around 30% rise in specifically the creatinine, I suppose. That's just so this much is okay. If it's beyond that, then we need to stop the drug. So continue parameter. Let's just check the creatinine. This has increased. It is increased by around 20 or 80. Urea is okay. Potassium. You can, I suppose, continue and repeat. Let's just check the question. Whether you need to do a urea and electrolyte in 1 to 2 weeks or whether you need to stop it. Yeah, the answer is continue and repeat urea and electrolytes. You need to understand okay, how much rise is expected. So you can increase by 30% can be tolerated. Following the start or increase in the ACE inhibitors, but urea and electrolytes should be repeated in 1 to 2 weeks. And if the increase is greater than 30%, then ACE inhibitors should be stopped. There's no beating around the bushes. No. Yeah, so three things you need to remember that you expect 30% rise and you will repeat after 1 to 2 weeks. And if it is more than 30%, you should directly stop. What are the contraindications of ACE inhibitors? Contraindications, pregnancy, breastfeeding, renovascular disease, renal artery stenosis, all these will actually impair the renal function. Aortic stenosis, because it will cause hypotension. If the patient has got hereditary or idiopathic angioedemas, specialist advice should be sought before starting ACE inhibitors in patients with potassium more than 5. So you cannot start if it is more than 5, you need a specialist. Patients receiving high dose diuretic therapy, more than 80 milligrams furosemide, significantly increases the risk of hypertension. Monitoring, as I said, from the baseline potassium up to 5.5 millimoles. A rise in the creatinine and potassium may be expected after ACE inhibitors. A 53-year-old gentleman is reviewed in clinic due to normal blood tests and he has past medical history of hypertension type 2 diabetes, obesity, and depression. And he started taking atorvastatin 2 months ago due to a routine assessment of Q-risk and elevated cholesterol level. Now, he had blood tests as requested at 3 months following the start of treatment, and these showed that his alanine aminotransferase have increased from 28 to 94. Now, other blood tests have remained within normal ranges apart from cholesterol, which has improved from 5.5 to 4.9. Now, how should his atorvastatin treatment be managed? Stop atorvastatin and repeat LFT within 4 to 6 weeks. Continue or change it. Uh, Investigate to elevate creatine kinase and stop it. What are the problems we are having here? That the ALT is jumped, the deranged LFT, cholesterol has improved. So, what will be your line of management in this case? What we'll do is that since the cholesterol is improved and I think this much is tolerable, you will continue atorvastatin and repeat the liver function test within 4 to 6 weeks. Okay? So, as per the 2014 guidelines, the correct answer is to continue atorvastatin, repeat LFT within 4 to 6 weeks, and this patient has developed elevated transaminase following starting a statin, but these are within 3 times the upper range of normal. Now, please note that this is 3 times the maximum normal range and not 3 times above the patient's baseline. Maximum normal range. Therefore, it is acceptable to continue atorvastatin, but liver function tests to be monitored. Statins inhibit HMG coenzyme amino reductase inhibitor, and it is the rate limiting enzyme in hepatic cholesterol synthase. So you just get rid of it and then you stop the cholesterol synthesis. What will be the most important adverse effect is the myopathy. There will be myalgia, myositis, rhabdomyolysis, asymptomatic raised creatine kinase. There will be risk factors for myopathy, including advanced stage, female sex, low body mass index, and presence of multi-system disease such as diabetic mellitus. Liver impairment, 2014 NICE guidelines recommended checking LFT at the baseline 3 months and 12 months. Then treatment should be discontinued if transaminase concentration repeat 3 times up the upper limit of the reference stage. It might increase the risk of intracerebral hemorrhage in patients who previously had a stroke. This effect is not seen in primary prevention. For this reason, Royal College avoids statins in patients with history of intracerebral hemorrhage. What are the contraindications? Macrolides, because they will have an important interaction with clarithromycin. You have to stop statin until you complete the course of these drugs. And the other is pregnancy, because statins are known to be teratogenic. Okay, so whom do we start statin in established cardiovascular disease, like stroke, in TI, ischemic heart disease, and peripheral artery? To have a Q risk score of more than or equal to 10%. Type 2 diabetes should be reassessed with Q risk. Type 1 diabetes were diagnosed more than 10 years ago or age over 40. For primary, we give 20 mg. For secondary prevention, we give 80 mg. So what you do, you check the cholesterol level after around 4 weeks. And if the non-HDL has not reduced for more than 40%, then you will increase the dose of atorvastatin. That is how you will go about.